I think we've got 3 speakers today, so joining the effort. Jonathan Weir-McCall, which is our lecturer in radiology, and Jonathan has been absolutely wonderful in the COVID work we've done, especially with the cardiac stuff input. Jude, which we all know for a while now, so chest radiologist again, absolutely instrumental in the consortium, and Ian Selby is my PhD student funded by Dragon, which is an H2020 grant to do the work between us and Carola at the Department of Mathematics. So really providing a bridge between the two to do this work. So I think it's been amazing 1 year or a bit more since the deep lockdown when the consortium was formed. And I think it's been just absolutely delightful to have carried out that work, and kudos to you guys, because you've been really the driving force behind that. So I don't want to say any more, but over to you, and I'm really looking forward to a fabulous talk.
Good afternoon. Thank you for having us. I'm going to start. So thank you for a wonderful introduction, by the way, Evis. I will share my screen. Okay, can everyone see the first slide?
Yes, we can see that, Ian.
Yeah, you can see it, great. Okay, perfect. So we've got a number of things we're going to talk to you about today. I'll start by going through the story so far of AI and COVID-19. Then Jude will move on and talk about imaging in COVID-19, and I'll then talk about our project that we've been working on for about a year now. And finally, Jonathan will talk about the calcium scoring and its uses in COVID-19 as well. So you may have been aware about a lot of the hype that there's been about AI and COVID-19. You may have seen stories such as this one, saying how a scientist could predict COVID-19 based on a patient's chest X-ray with with a 98% accuracy, which is quite impressive given that PCR is only about 80% accurate. So you might be thinking, well, why aren't these being used all the time to improve our diagnostic accuracy? Well, if you take a look at these images, these are images taken from one study, which, and you can see some normal images and some COVID-19 images, and you might be able to spot some fundamental differences between the two sets of patients. I'll just give you a couple of seconds to have a look if you can see. And what the cases is there, the normal cases were all of children, so generally infants under the age of 5, and the COVID-19 cases were all of adults. So all the algorithm was doing was telling an adult from a child and then getting a mark for spotting COVID at the same time. So this is just a demonstration of how the models can like to cheat. So before we to inform our work, we did a systematic review and looked at over 2,000 papers, of which only 61 passed our quality reviews. And what we found that was none of the literature at the moment reaches the threshold of robustness and reproducibility to support that being used in practice within the clinical setting. Now, as part of that, we discovered a number of lessons that I'd like to kind of share with you now. So the 3 main sources of error were split into themes. So data sets, methodology, and clinician involvement. So often the data sets were quite small, or there were public data sets where which isn't necessarily a bad thing, but it's sometimes difficult to know exactly where your data's come from and what the quality is and what the demographics of that are. So for example, one of the phenomena we saw was Frankenstein data sets. Now in a Frankenstein data set, you can have one data set such as the SIRM data set, which is included in the IEEE, I'll call it a data set, but also in the COVID-19 radiography data set. And the IE data set is included in the radiography data set, both of which are then in COVID-X. So if you took COVID-X for your data set, you would inadvertently be taking the SIRM data set 3 times. And that poses problems in terms of validation, splitting your data set up, because you could be training and testing on exactly the same images. So the other problem with public and small data sets might be some forms of implicit bias, but also sometimes the data wasn't quality controlled as well. And I will come on to that in a moment. But just to talk about implicit biases a little bit further, there was a study done that actually took the chest X-rays and drew a big black box over the lungs to see if you could tell, if you could detect COVID-19 without the lungs rather than with them. And what they found was that they obtained very similar, well, almost comparable results by blocking out the lungs as they did with them, which just demonstrates how easy it is for algorithms to cheat by looking at the information around the image. And I'll come on to that a bit more in a moment. In terms of the methodology, often demographics were unpublished or unsuitable. And as I alluded to with the small data sets, often there was inadequate external validation. So the models were only tested upon the data from the same institution as which it was trained. So we have no idea whether that model can generalize to other institutions or be used in different settings. And finally, a lot of the time, the performance was only compared to the PCR test and not to a radiologist. So that might be unfair because the PCR test is, wrong one in 5 times, but also it's possible to have COVID-19 and be positive without having any changes on your chest X-ray. So that seems a little bit unfair as well and quite a biased way of doing things. And in terms of the clinician involvement, the lack of involvement in clinicians often meant that there were certain implicit biases that were ignored. For example, this is one of our chest X-rays where you can see how the image, well, how the model is choosing to take the judgment based upon the text on the image rather than what's actually going on in the lungs itself. So saliency maps like this, which give you an idea of what the model is weighting to make its decision, can show you some of the implicit biases within your data. And it might be that only a clinician would know that if you have text or annotations on your chest X-ray, you're more likely to be having maybe a mobile chest X-ray or an X-ray in ITU, and therefore are more likely to have COVID or be sicker. Okay. So in terms of what we can do about the problem, we can acknowledge that there's a small data problem and do things about it. Often this was ignored. We can look at trying to streamline our data acquisition. So when we have pandemics or when we have unexpected events, we can get data quickly rather than having quite a slow process to get through the ethics and regulation to be able to get the images. But also we can try and source some original data and carefully curate and examine it. And one example of some work, although not perfect, is the NHSX NCCID data set that we contribute to. and Amy has been working really hard to collate the data for them. But that contains images from 23 trusts across the country of about 9,500 patients and over 25,000 chest x-rays and 4,500 CTs. So that really does, it's kind of initiatives like this that will really help us in the future to get large enough data sets and the generalizability to make sure that things work. Okay, and in terms of improving methodology, there are some excellent checklists out there, such as the claim checklist and the radiomics quality score, which can help guide you in what you might be missing. And finally, it's important to work as a multidisciplinary team, involved clinicians, and ensure that the clinical conversations are had with the kind of more techie maths guys. And my final point on this as well is to ensure that there's a robust peer review process where the review is adequately informed of AI and know what to look for to ensure that poor research doesn't get past them. Okay, so now I'm going to pass on to Jude to talk about imaging in COVID-19.
Thanks, Ian. So hello, everyone. So I think you'll all be quite familiar, unfortunately, in what imaging there is in COVID-19 and what it looks like. But I just wanted to just take you through it in particular with reference to AI. So I'm going to start with by looking at a pathology slide for my first slide, and that's because it's really important that we correlate all our imaging back to the histopathological process that we see with COVID-19. And the primary histological manifestation in COVID-19 is of a diffuse alveolar damage pattern. Now, all that means is that basically the lung has had an insult. So this insult could be from COVID-19, but also we'd see the same pattern of lung injury with other infections, or with, for example, a drug reaction or a connective tissue disease like an autoimmune disease, or inhalational injury. So it's the same pattern of pathology that we'll see in all these things. And what happens in diffuse alveolar damage is that there's 3 stages. There's the exudative phase, which is where you get, so you get edema of the interstitium and of the alveolar walls, and also you get exudate within the intraalveolar itself. So that's why you see this ground glass opacity in the lungs. That phase lasts for a couple of weeks, and then in some patients you'll go into a more organizing phase, and that's when you start getting intraalveolar granulation and more thickening of the alveolar walls. And all these things is why you get reduced diffusion and why you get reduced hypoxia, because of the reduced diffusion capacity along the alveolar walls. In most patients, this organizing component will resolve, but in some small proportion of patients, you might start getting fibroblasts causing fibrosis, which is why we might see some fibrosis in patients long term. It's not just diffuse alveolar damage that's the main problem in COVID, or that is the main problem, but the other things that are coexisting are things like alveolar hemorrhage, areas of arteriolar thrombosis or capillary thrombosis, which is why we saw PEs and immunothrombosis. You also get foci of bronchopneumonia and infarction. So these are the appearances you're going to see on chest x-ray that we're all, unfortunately, all too familiar with. So it can be anything from quite mild or almost like a normal chest x-ray with some subtle basal peripheral ground glass opacities to a moderate changes in the middle, which reflect peripheral and basal ground glass opacity, to a much more severe ARDS kind of picture with diffuse alveolar damage pathologically as diffuse ground glass opacity or consolidation. So the CT features are similar. We see ground glass opacity often in the initial stages of disease. It was unilateral or asymmetrical, and the ground glass opacity, if you I'm not sure if you can see my cursor, I hope you can. But anyway, within the ground glass opacity, you can see that the vessels were enlarged, and that was one of the features that was subsequently found out with COVID pneumonia. But you tend to get these peripheral opacities in the lungs. You can also get nodules such as these ones in both lungs with a more solid center and a ground glass halo. Again, we see this in other causes of organizing pneumonia, and you can see it with fungal infections. And on the image on the right, you see more typical appearances of organizing pneumonia with these areas of perilobular consolidation. So the consolidation is surrounding the lobule, which is a typical pattern of organizing pneumonia. With more extensive diffuse alveolar damage, we'll see diffuse ground glass opacity. You might see some crazy paving appearance. And then in severe cases, you can have almost the whole lungs replaced by diffuse consolidation, as in this example. So I've described all the CT features. There are CT features which would be against COVID pneumonia, which are also quite helpful. So things like cavitation, lymphadenopathy, pleural effusions. So what tends to happen in patients in the first sort of 3 or 4 weeks? Well, we generally saw from the initial sort of more unilateral to bilateral disease with increased ground glass opacity. So this CT was from the beginning of March. About a week later, we've got more diffuse ground glass opacity. And then when we're more sort of 3 to 4 weeks out of disease, we start seeing the resorptive phase. And that's when you get a reduction in the extent of ground glass opacity. This is the same patient. So we've got reduction in ground glass opacity, but we're starting to see these sort of curvilinear lines and subpleural parenchymal bands. We also started seeing irregular bronchial dilatation. Now, it's very tempting to call this traction bronchiectasis, but I would try and implore you not to call it traction bronchiectasis. And that's because we see traction bronchiectasis in the setting of fibrosis when we see reticulation. And this is an irreversible sign. But what we can have seen with COVID pneumonia is that these irregular bronchi that you want to call traction, but you're not, is actually reverses over time. So this was the CT sort of 3 months later, where actually the traction bronchiectasis isn't traction bronchiectasis at all, it's just normal bronchi now. So it's really important that we're not overcalling fibrosis at this stage. So how about much later on? How about 6 months or later? Are there any sequelae? So the majority of patients will hopefully resolve the abnormalities that they had at baseline. So this was a patient with diffuse ground glass opacity and their lungs look pretty normal 4 months later. There aren't many studies out there at the moment. There's been a couple, but remember, these are going to be super biased because they're only going to be CTs that were performed on patients with severe COVID. So all the patients that weren't hospitalized will not be included because they won't have a CT. And there was a recent London study that was just looking at chest x-rays for patients that were admitted, and it said after 6 months, about 60% of those chest x-rays would resolve. This study was looking at CTs, and it said in about a third of patients at 6 months or later, they had fibrotic-like features. Again, I'm a bit unsure that these are really fibrotic features, but I think it's important to be mindful that these changes may resolve. About 40% had complete resolution, but interestingly, those that had abnormalities at 3 months then resolved by 6 months. So it really shows that COVID pneumonitis is taking a long time to recover, but it's really important that we don't just call this fixed fibrosis. The fibrotic-like changes were associated with older age, clinical diagnosis of ARDS, and more severe CT lung involvement at baseline. So that's not really much of a surprise. And then this is this study in the Lancet. Again, it wasn't really an imaging study, but they did look at CT, again on hospitalized patients, but much larger numbers. So 1,700 patients were looked at. And they compared patients with different severity, so those not requiring oxygen compared to those that were ventilated. But across all groups, they said at CT at 6 months still showed at least one abnormality, and the commonest abnormality was of just some residual ground glass opacity. So what I wanted to sort of conclude was that the imaging appearances of COVID-19 are really just reflecting this diffuse alveolar damage process that we can see with multiple diseases. So as radiologists, we're never really going to be able to tell that it's COVID, apart from when the prevalence of disease is high. But what is interesting is that AI may be able to tell us some subtle things that we couldn't see that might be able to distinguish these different causes. but also it's an amazing opportunity out of obviously a tragic pandemic, that we suddenly got this amazing opportunity of having thousands or millions of scans and patients presenting with the same disease worldwide, which we normally would not be able to get such a big database. So hopefully that we can actually use the AI to teach us how we can use sort of where we can use it in clinical practice from COVID experiences. And as a radiologist, the things that I would like the AI to be able to help me with personally are things like giving an objective severity score of how much airspace or ground glass opacity there is. So the BSTI, when guidelines initially, when the pandemic started, asked us to grade chest x-rays and CTs with sort of mild, moderate and severe. But our concordance amongst radiologists was terrible. And also it's very hard to say, to grade severity. So do you just grade it by which zones are affected? So it might be, there's not much disease, but all the lung zones are affected, so they get a high score. Or do you just do it on the percentage of lung involvement? We don't know, but this is somewhere AI could really help us. It'd be great if AI can integrate all the clinical data, so look at things like sex and age and ethnicity and comorbidities before they've even looked at the imaging, to help us, for example, give prognostication data, and also sort of just to aim on who we should be following up. So the BTS guidelines say we should probably follow up nearly every patient with COVID. And I've sort of tried to push back that a bit at Addenbrooke's, because is it appropriate to bring back somebody who's got multiple comorbidities in a nursing home just to get imaging? I mean, it doesn't seem that that's a good use of imaging. So could AI help us in who we should be following up? Okay, back to Ian.
Thanks, Jude. So now I'd like to talk to you about our project here at Cambridge. So I'll start off by talking about the collaboration in Cambridge between the radiology departments and the Department of Applied Mathematics and Theoretical Physics, and also CUH. So in response to the pandemic last year, various members of the groups came together and formed a collaboration in addition to their normal working routine, led by Evis and by Corolla in mathematics. And we've managed to put together quite a large consortium of partners and pulled together a lot of imaging data. As you can see here, we've got imaging from across the globe. And we've managed to pull together quite a large number of patients, which hopefully gives us a data set which we can do a lot of good work with. Now, as part of the collaboration, for about a year, we've been having daily meetings that were 5 p.m. and then 4:30 and so on. But it's been a really unique experience having daily Zoom meetings with a large group of people from all over the place. So it's been a really great experience for us all. And many of you may have heard us talk about Dragon, which is where my funding comes from. And that's a IMI EU funded project to look at diagnosis and prognostication in COVID-19 for institutions and small and medium-sized businesses across Europe. And we're looking at all sorts of things from diagnosis and prognostication with imaging. So they're going to do some federated learning, giving us the model to run and then send them back the results. But also there's members of the consortium looking at sputum testing and building long COVID apps and all sorts. So it's been really a great experience to be part of that. Now, here in Cambridge, going back to our collaboration, our primary goal is to be able to fuse various data sets and feed it into AI and then give us some data with which we can make decisions about patients. Now, if you were a clinician in A&E, you wouldn't base your judgment on the chest X-ray alone. you would look at any other imaging, any blood tests, the observations and the patient. So it makes sense that we should be able to get better results with more data. Now, one of the big questions early on was what to look for, and certainly early in the pandemic, everything wanted diagnosis. Could we make something that would diagnose, because we had limited testing capacity? It took a few days to get the test result back, and there was really hunger for a solution to that. So there was lots of work in the literature and so forth. But the other question, which has perhaps become more and more interesting, is the idea of being able to prognosticate. So can we tell who's going to deteriorate and who's not? Because a lot of the time it can be quite a unpredictable disease, with younger patients who seem quite fit and healthy having severe disease, and then patients you would expect to be in a bit more trouble who come away relatively unscathed. So once again, going backwards, I'll now go into the automated data curation that we're trying to do. So making sure that the data we feed into the model is of good quality, because you can do all the tinkering in the world with your models, or developing slightly better models that improve performance by 1% or 2%, but improvements in the quality of your data and the data that you feed your model can really improve results. So for this, we've kind of taken the approach that we wanted to have the best possible data we could, and to try and not cut corners and not do the boring stuff, I suppose, and make sure we go through our images in detail. So we built an iPad kind of GUI or app to do many labels for the different ways in which we thought that a chest X-ray could be biased. So whether that be the projection, or whether it's got a black box around the edge, or it's slightly rotated, or the patient's rotated, and so on. So we ended up, we've got quite a nice data set of the various differences between chest X-rays now together. I think we've got we're coming up to about 10,000 that have been labelled. So one of these, for example, is projection. So whether the chest X-ray is AP or PA, and you might think, so what? But obviously, particularly in COVID, we were using the mobile scanner to do our COVID chest X-rays for COVID positive patients. So they tended to be AP more than they were PA. And also sicker patients obviously tend to get an AP rather than a PA. So that introduces some biases given the differences in the two images. I won't dwell on this, but just to kind of show how the models can pick out the differences. You see here with this saliency map showing where the model is looking, that two of the hotspots further up are very much overlying the inferior scapulae. So the models can definitely cheat if you allow them to. And yeah, these are just some other examples where, for example, the grayscale is inverted on the image. So is there some kind of hidden bias in the inverted images? Lateral projections, which are fine if you're training a model with lots of lateral projections, but otherwise they just introduce noise. And also dual energy chest X-rays, making sure that we only feed a model the right energy scan. So given that we've got this massive data set and looking at chest X-rays is quite time consuming, we're looking at how we can automate as much of the process as we possibly can. So we've developed models to auto label a lot of these features, for example, pick out the inverted images, and that has, I think it's 98.5% accuracy, pick out laterals, pick out the projection, and so on. And then those things that we can correct, so for example, the inverted scans, we can flip the grayscale back. If the image is rotated and got a box around it, we can trim the box and rotate the image. And images that have got annotations on, we can read the annotations off the image and take that data and use that for labeling too. And another example, going back to the projection, we trained a projection model which is able to predict, state whether the scan is AP or PA, and that's got an accuracy of about 88%. So it shows that models can tell the difference and therefore are able to cheat. Okay, so moving on to the different themes of the project. We're looking to fuse chest x-rays, CTs, clinical data such as blood tests, observations and so on, but also some flow cytometry. So I'll just briefly touch on all of those. So chest x-rays. We developed a chest x-ray diagnosis model. Was it, I think earlier this year, last year, which was based upon a pre-trained model that we developed using a data set called Chexpert. And Chexpert is a huge data set of chest x-rays that's been labeled. It's good quality, and it gives you kind of a good platform with small data sets to be able to utilize that. And then you can fine tune it and use the kind of model weights to apply them to COVID-19. So we took that pre-trained model that we developed. We trained it with different resolutions of scans, high and low resolution, and then we fine-tuned it using COVID-19 imaging from Addenbrooke's and also the NHSX data set I talked about earlier. Now, after some quality control, we ended up removing about 1,000 of 5,500 that we used initially, and ended up with a COVID positive set of about 1,500 and about 2,500 COVID negatives. And then we looked at using the full image, segmenting out the lungs, and then cutting the box of using the lungs as a boundary. What we found was that the resolution of the scan didn't make too much difference. And our thinking on that was that it makes more sense that the higher resolution data would be better, whether that is that it's getting too much information or it's trying to be too specific, as you can see from the saliency maps in the bottom right, not too sure. But we felt that probably the higher resolution image would be best to progress with. And as you can see from the bar charts, we got quite good results. So we were able to predict COVID with an accuracy of approximately 80 to 90%, depending on which model we took, around 0.85. And we're currently validating those results in a pilot exercise with NHSX, as they are looking to put together something to take models from developers and validate them on their behalf. So we're working with them at the moment on that project. Okay, so we also had some labels from the NHSX data set where the radiologist had predicted COVID or non-COVID or indeterminate. So because of the indeterminate label, we created what we called the conservative radiologist, where we put indeterminate with negative, and the aggressive where we put indeterminate as COVID positive. And if you put indeterminate as COVID positive, you did improve the accuracy. With indeterminate as negative, we're saying radiologists were only about 53% accurate, and that went up to 70% when making indeterminate positive. But you can see that from the 2 points on the chart and the curves going above, the models did outperform the radiologists in terms of prediction. but there's many reasons for why that might be. For example, it was early in the pandemic. We weren't necessarily sure what we were looking for, or whether, and testing wasn't as widespread and so on. So going forwards, we decided that the full images, well, we found that the full images often put too much weight on the annotations of the images. So we're using cropped images where we cut away the majority of the bounding material in the images to try and remove that bias. But on the cropped images, we did find that the models were looking more within the lungs than they were outside, so that was quite promising. One thing that did concern us was that, did we have a model that was actually detecting COVID, or was it just an opacity checker? Which is why we kind of haven't really pushed on at this stage to publish that, because it depends on the utility, I suppose. But we wanted to make sure that we could get some COVID mimic data sets and see whether we can spot the difference between different conditions, because diagnosing someone with COVID when they don't necessarily have it isn't necessarily helpful, particularly as prevalence falls. And also we're going to look at incorporating it with the other data streams, in particular the clinical data. So we're also working on CT at the moment. So we've got some automated segmentation algorithms to segment out the ground glass opacity in the lungs for us. And then we're combining that with the clinical data to see whether we can predict adverse events such as ITU admission or need for ventilation or death, being mindful of the biases of things like DNA, CPR, forms and so forth. So yeah, and then we're also looking at clinical data. So we've got a large amount of clinical data from Addenbrooke, which is brilliant because of the EPIC system. And this was some early work from last year, but we were able to predict death within a 3-day window with a sensitivity and specificity of about 80, well, sensitivity of about 80, 0.8, and specificity of about 0.9. So although there's still a lot of work to do there, that was quite promising as an early sign. So we're currently developing some further models for that. And then finally, just mention the blood cell analysis. So there's a group led by mathematics called Blood Counts, which have just been successful in the Trinity Challenge, amazingly, and have got significant funding to push on with this idea, where they use flow cytometry to look at the produce scatter plots of different properties of the blood cells in a full blood count. And given that there's millions of full blood counts done every year, it gives them a huge amount of data to work with. And they're looking at whether you can, well, primarily whether you can tell, whether you could predict a forthcoming pandemic from the kind of noise in the full blood counts nationally. But also where it might help us out is if we can feed this data into our model, it might help us determine between COVID-19 and other conditions, or to help us predict prognosis from the full blood counts. And that is it for me. So I'll pass on to Jonathan.
Thanks, Ian. Fascinating stuff there. Are you going to pass the screen control across to myself then?
Yes, of course. Just send it across, Jonathan.
Excellent, thank you. So yes, everyone on the meeting who's familiar with me will know that I'll always try and force any discussion back towards the coronaries and the heart. And although the talk today is about COVID, I'm going to try and convince you that calcium scoring is super important for this as well. going to move forward. Yes, it is. So, you know, calcium is a marker of atherosclerosis, and atherosclerosis has been with us pretty much as long as we've existed as humans. We try and sometimes pin it as a, you know, a consequence due to unhealthy living habits, but we can look back 6,000 years in mummies using CT scanners, and we find vascular calcification in almost half of these individuals.
I think Jonathan's connection is broken, right? Or is it only me having that problem?
Sorry, I'm. It's
Jonathan, I lost you now, but maybe just me rather than.
Can you hear me now?
Now I can. Perfect. Oh, we can rather.
Excellent. We know calcium's been around for a long time, but it's also terribly useful in day-to-day clinical practice. And this is looking at over 66,000 patients, looking at all-cause mortality as well as cardiovascular mortality. And as we move from people with no calcium in the red at the front of the screen to the grey at the back of the screen, you can see that the risk of all-cause mortality and cardiovascular mortality rises exponentially as your calcification burden increases. And what's even more fascinating is that if you then subdivide people with these calcium scores into the number of cardiovascular risk factors, including hypertension, diabetes, smoking, hypercholesterolemia, that if you've got 3 of these risk factors, but you don't have any coronary calcification, as we see in the bottom right of the 4 groups, that you have the same risk of death as someone who has no risk factors, but even just a tiny smidgen of calcification, as we can see in the green bars. So it's really useful at separating people out and identifying those at elevated risk. And this helps guide treatment as well. This was a study with 12 years of follow-up where they looked at patients who had calcium score of 0 or greater than 0 and those who had statins versus no statins. And if you had a calcium score of 0, you can see no difference between the dashed and solid line in mortality between those who did and didn't have a statin, whereas you can see those lines separating really nicely if you have a calcium score greater than 0. So evidence of atherosclerosis shows that you're going to gain benefit from this statin therapy. And indeed, you'd need to treat more than 3,000 patients in a calcium score of 0 to potentially save 1 life, although you might actually counterbalance that with causing harm second to statin therapy. Whereas if you focus on those who have a calcium score of over 100, you only actually need to give 12 of them therapy to prevent a downstream cardiovascular event. And my favorite use of it to date is to predict whether you're going to die of cancer or cardiovascular disease. So if you look at your calcium score, you look at your age and your sex, if you are in the red zone, you're more likely to die of heart disease. And if you're in the blue zone, you're more likely to die of cancer. So trying to bring us back on topic, slowly migrating back towards COVID. So all of this has been talking about gated cardiac CTs, but we can get largely the same information from non-gated cardiac CTs. And this was a study comparing the 2 in patients who had both a gated cardiac CT and just a standard HRCT chest. And you can see a beautiful alignment and agreement of scores. So we can now start to extract quite confidently this calcium information from standard chest CTs, such as we acquire in COVID, and start to look at them for the calcium. And certainly in the Nelson trial, which was a lung cancer screening trial where they did extract the calcium score from low dose chest CTs, we can see that it predicts very nicely downstream risk of both all-cause mortality and cardiovascular specific death. And this is of importance in COVID because we see that if you've got cardiovascular disease on admission and you happen to have an elevated troponin alongside that, you've got a 69% mortality rate, which is absolutely stratospheric. And if we look at those who do have elevated troponins, we can see that there's a very high burden of hypertension, pre-existing known coronary heart disease, diabetes, and prescription of antihypertensive medications as well. So this elevation of troponin can be a surrogate of silent and undiagnosed cardiovascular disease, which is where the calcium score can potentially come in very useful. And indeed, in one study in Italy where they looked at 1,000 patients across 6 centres, they found the calcium score to be very useful at separating those who are going to have poor outcomes versus those who are going to survive to discharge. However, one criticism of this study, and it's always going to be a challenge whenever we're looking at the first wave of COVID, was that we know that calcium score increases with age. And we also knew that particularly in Italy, which was one of the first European countries to be hit by COVID, they were having to choose who was going to progress onto ventilator therapy, with age being one of the strong determining factors of whether you got escalated therapy or not. So could it simply be that you were likely to die with a high calcium score because you were older and therefore deprived of non-invasive ventilation? Or is this actually a useful surrogate marker? And I think this is where we're going to have to start drilling down with some of this beautiful data that Ian's been talking about over the last 20 minutes. But I'm sure we can all agree, especially since we're talking about numbers in the thousands rather than scattered dozens, we don't want to be sitting and drawing circles around lots and lots of calcifications endlessly. We want that all to be done for us. And in fact, ideally, we want this done for us in routine clinical practice as well. And this is a study that was just come out earlier this year, very nicely done, where they trained it in 1,600 patients, and then they looked at 4 existing cohorts entirely independent, which were done with both gated and non-gated CTs for a variety of indications, testing the testing the AI algorithm that they derived in this 1,500 patients in over 20,000 patients to determine its accuracy. And importantly, there was a very high agreement between the deep learning and the expert reader, as we can see in this chart on the blue on your far left. And whenever there was a disagreement between the two, that disagreement was almost always just by 1 grade of severity of calcification. We then had a sub-cohort of patients within this paper who had 2 CTs within an hour of one another. So we could then examine how well the computer agrees with itself whenever exposed to the same data set from the same people, but on 2 separate scanning intervals. And again, incredibly high concordance rate, 0.85. And if there was any disagreement, it was almost invariably just 1 grade of severity of calcification out. And the level of agreement between the 2 scans was largely the same between the deep learning algorithm and between the expert readers, as we can see in these 2 orange charts in the middle and on the right there. And this very nicely separated out those who are at very low risk of cardiovascular events and those who are at very high risk of cardiovascular events. And this was true in the NLST test cohort, which was a lung cancer screening cohort, and in the PROMISE test cohort, which was a group of patients presenting with stable chest pain, and the Weir-McCall test cohort, which was patients presenting with acute MIs, presenting to A&E with acute onset chest pain. So therefore validated in quite a nice and diverse range of patients presenting with a wide range of symptoms. So now the intention is to combine the quantitation of the lung disease along with the quantitation of calcium to see if we can truly add to the risk stratification for prognosing and triaging of patients. However, I think we can push beyond that because you know, once you're over your COVID episode, you're still at increased risk of cardiovascular events. And in fact, you might be at an even greater risk of future cardiovascular events for having had COVID than if you hadn't suffered an episode of COVID at all. And one of the reasons I say this is a meta-analysis of the effects of flu vaccines on downstream cardiovascular events. And we can see 36% reduction in major adverse cardiovascular events in the winter following flu vaccination compared to if you didn't get the flu vaccination. So there's something about the flu, most likely that atherosclerosis is an inflammatory condition, and so is a lung infection, and that one helps accelerate the other. So therefore, if we have one, we need to be very aware of its impact on the other. And the image on the left here is courtesy of Dr. Teng in the department, of a patient who had multiple scans or two patients who had multiple scans over the duration of their inpatient stay for COVID. And in both of them, we could see the sudden appearance or marked progression in their coronary atherosclerosis over the duration of the 2 to 3 months of their infection. And this matches what we might expect from prior studies in pneumonias, where if you had high atherosclerotic cardiovascular risk, as connoted by hypertension and hypercholesterolemia and diabetes, that if you had an episode of pneumonia, you were much more likely over the subsequent years to have an increase in your coronary artery calcium score over interval imaging than if you didn't have an intervening pneumonia. So there's definitely an interaction between the two, and I think this AI algorithm and this cohort that Ian and Carola and Avis have all brought together will allow us to study in far more detail, and hopefully try and reduce downstream risk through the identification of these high risk groups, and hopefully better understand this interaction between lung disease and heart disease and the inflammatory miasma that's going on with this condition. So in conclusion, we can hopefully accelerate and streamline quantitative assessment in non-contrast disease, both COVID, non-COVID, stratify acute risk, and understand this interaction. And with that, I will pass you back to Avis, and thank you all for your time this evening.